Why do PKD1 and PKD2 mutations lead to different ADPKD outcomes? Imagine two different keys opening the same door, but one unlocks it more quickly and with more force than the other. That's similar to how mutations in the PKD1 and PKD2 genes affect polycystic kidney disease differently. Both genes are involved in a condition called autosomal dominant polycystic kidney disease, or ADPKD, which causes cysts to form in the kidneys. But the way these genes work and how mutations impact them lead to distinct disease courses. Most cases of ADPKD are caused by mutations in the PKD1 gene, making up about 80 to 85% of cases. These mutations tend to cause a more aggressive form of the disease. Patients with PKD1 mutations often develop larger kidneys filled with cysts and face kidney failure earlier, usually around age 55. On the other hand, mutations in the PKD2 gene account for about 10 to 15% of cases and generally lead to a milder disease. These patients tend to develop kidney failure much later, often around age 75, and their disease progresses more slowly with fewer complications. The reason for these differences lies in the roles of the proteins these genes produce. The PKD1 gene makes a protein called polycystin-1, which is a large membrane protein involved in how kidney cells stick together and communicate. It acts as a sensor that helps maintain the structure and function of kidney tubules. The PKD2 gene produces polycystin-2, which functions mainly as a calcium channel, allowing calcium ions to enter cells. This calcium signaling is essential for normal kidney cell activity and health. When mutations occur in PKD1, especially those that truncate or completely inactivate the polycystin-1 protein, the disruption to kidney cell regulation is more severe. This leads to faster cyst growth and more rapid decline in kidney function. PKD2 mutations often involve nonsense mutations that cause loss of function but tend to preserve some level of polycystin-2 activity, resulting in a milder disease course. The types of mutations also matter. PKD1 mutations are often truncating, meaning they produce a shortened, non-functional protein, which results in more aggressive disease. Some PKD1 mutations are non-truncating, causing less severe effects. PKD2 mutations are usually nonsense mutations that lead to loss of protein function but tend to have less impact on disease severity compared to PKD1 truncating mutations. Clinically, this means that patients with PKD1 mutations need closer monitoring and earlier interventions to protect kidney health. They are more likely to experience complications sooner and requiring treatments like dialysis or transplantation earlier in life. Those with PKD2 mutations generally have a slower disease progression but still need regular checkups to keep track of kidney function. It's important to note that while ADPKD mainly causes cyst formation, there is no direct link between PKD1 or PKD2 mutations and kidney cancer. However, having chronic kidney disease and cystic changes can increase overall health risks, so ongoing medical evaluation is essential. In summary, the key difference between PKD1 and PKD2 mutations lies in the functions of their respective proteins and how mutations disrupt those functions. PKD1 mutations tend to cause more severe disease because they lead to a greater loss of function in polycystin-1, resulting in faster cyst growth and earlier kidney failure. PKD2 mutations usually result in a milder course because the impact on polycystin-2 is less severe. Understanding these differences helps doctors predict disease progression and tailor care for each patient. If you or someone you know has ADPKD, it's always best to consult healthcare professionals for personalized advice and management.